Hello everyone. This is Physiology in Small Doses. I will be discussing a mixed bag of 10 questions, but these are actually 10 very important topics as far as your exam is concerned. So let's start right away. And the first question that I'm going to discuss is, which of the following is an insulin-dependent GLUT? Now, what is GLUT? GLUT is a glucose transporter, and this is an example of facilitated diffusion. What is facilitated diffusion? It is a type of passive transport, but which is carrier mediated. There are proteins which are involved, and there are different types of GLUT, GLUT 1, 2, 3, 4, and so on. But the one which is insulin dependent is GLUT 4, and this is what is present on adipocytes and on muscle cells. All the others are insulin independent. So let's have a brief look at this table, extremely important from an examination point of view. We've already discussed GLUT 4, which is insulin dependent. GLUT 1 and GLUT 3 are present on the brain and placenta. GLUT 1 on RBCs as well. GLUT 1 is in kidneys, but please remember the major GLUT which is present in the kidneys is GLUT 2. Remember, 2 kidneys, GLUT 2. Small intestine also has GLUT 2. GLUT 5 is a very important fructose transporter. This is present in the jejunum, on the sperms. This is a specific fructose transporter. So these are important points which you have to remember from this table. Let's have a look at the next question. It says, a 45-year-old female patient presents with intermittent, sudden, violent, involuntary movement involving the right upper limb. This is due to lesion of which of the following? This is a typical picture of something called a hemibalismus, where there are violent movements of one half of the body. And this is seen in a lesion of the subthalamic nucleus of Lewis. So let's have a look at the different ganglia, different components of the basal ganglia. There is the caudate nucleus, putamen, globus pallidus, external segment, internal segment, substantia nigra, pars compacta, pars reticularis, and subthalamic nucleus. Now remember, caudate nucleus and putamen together form the striatum. And remember, 95% of the striatal neurons will secrete GABA and 5% secrete acetylcholine. Globus pallidus, external segment, internal segment, both secrete GABA. Substantia nigra, pars compacta, dopamine, pars reticularis, GABA, subthalamic nucleus of Lewis, glutamate. Now, what are the different lesions? A lesion of the caudate nucleus causes chorea. And what is chorea? Flicking movements, involuntary movements, which are typically described as flicking movements. A lesion of the globus pallidus causes athetosis. What is athetosis? These are slow writhing movements like that. These are dance-like. A lesion of the substantia nigra, pars compacta, loss of dopaminergic neurons of pars compacta is responsible for Parkinson's. A lesion of the subthalamic nucleus of Lewis causes hemibalismus. Of course, Parkinson's, we know the features of Parkinson's. There is bradykinesia, akinesia, shuffling gait, loss of facial expressions. There is tremor at rest, those pill rolling movements, etc. Let's go on to the next question. Which of the following statements is correct regarding secretin? Secretin is secreted in the small intestine by the S cells. S cells will secrete secretin. These are present in the upper small intestine, and the role of secretin is to increase the bicarbonate secretion in the pancreatic juice. This is extremely important because we know that the gastric chyme is acidic. To counter that, the pancreatic secretion will be alkaline. In fact, the small intestinal secretion, bile, these are all alkaline. What increases pancreatic enzyme secretion is cholecystokinin. What increases the gastric acid secretion is a hormone which is called gastrin. Secretin reduces gastrin release, does not increase it. So the answer becomes secretin increases bicarbonate secretion. Which of the following electrolyte imbalances results in an increased nerve excitability? Now, hyponatremia has nothing to do with nerve excitation. Hypokalemia causes a hyperpolarization, which leads to a decreased excitability, not an increased excitability. Hypocalcemia, on the other hand, this increases both the neuronal and muscle excitability. That is why carpopedal spasms, which is known as the Trousseau sign, Schwostek sign positive, this is seen in hypocalcemia. This is the Trousseau sign, which is seen in hypocalcemic tetany. Now, what is the physiological basis of this tetany? Let me explain that to you. Now, when I look at, this is a cell membrane. Here you have the sodium channels. And sodium channels have got two gates, one towards the ECF and the other one towards the ICF. Sodium channel is lined by a negative charge. And when both the gates of this channel are open, sodium will come from the ECF to the ICF. Sodium is in a higher concentration in the ECF, lower concentration in the ICF. Now, there is another cation in the ECF, which is calcium. So, calcium stands around the mouth of this channel like the chowkidar. C for calcium, C for chowkidar. And what is the role of a chowkidar outside a building? It regulates the entry into that building. That's exactly what calcium does. It does not stop the movement of sodium. It simply regulates it. It's a more controlled movement of sodium. But when the chowkidar goes on chutti, that means there is a hypocalcemia. Now what is going to happen is this, since there's no chowkidar, now there is an unregulated and very easy entry of sodium into the cell, increasing the neuronal and muscle excitability. We say that calcium has what is called a membrane stabilizing action. It regulates, controls the movement of sodium into the cell. So when there is a hypocalcemia and a loss of this membrane stabilizing action of calcium, it increases neuronal and muscle excitability. That is why carpopedal spasms, Trousseau sign or Schwostek sign positive. Let's look at the next question. It says, you are performing a CNS examination on a patient with a stroke. With his eyes closed, you move his big toe. You hold on to the metatarsophalangeal joint and then just move the big toe either upwards or down. And you ask him to state the position of the joint. That is basically you're testing for joint and position sense. Which of the following fibers is responsible for the transmission of the sensation tested here? Now, the joint and position sense, the most important nerve fiber is A-alpha. This is the largest diameter, fastest conducting nerve fiber. And proprioception or proprioception, this is the fastest conducted sensation. This is carried mainly by the A-alpha nerve fibers. Yes, A-beta also carry proprioception, but between the two, the better answer will be A-alpha. Fastest conducted sensation is proprioception. Which are the receptors for proprioception? Muscle spindles, Golgi tendon organs, joint capsule receptors. These are meant for joint and position sense. The formula UV by P, this is used to calculate the renal clearance. Clearance of any substance X will be equal to the urinary concentration of X into rate of urine flow divided by the plasma concentration of X. What is filtration fraction? Filtration fraction is GFR divided by renal plasma flow. What is the how do you calculate the excretion rate? Excretion rate is urinary concentration of X into rate of urine flow. How do you calculate the filtration rate? That is GFR into plasma concentration of that substance. So this formula UV by P is for the renal clearance. A cross-sectional view of a skeletal muscle through the H zone. Now, what is H zone? There is an A band, I band, and H zone. What is A band? A band is the dark band. As you can see over here, this is the A band. And what is A band? A band is myosin plus overlapped actin. This is the dark band. Now, which is the I band? I band is here. E is the I band here. What is E or the I band? This is only actin. Remember, half of I band lies in one sarcomere, half lies in the neighboring sarcomere. As you can see, this is the Z line here. This is the Z line here. Between the two Z lines, you have the structural and the functional unit of the skeletal muscle, which is called sarcomere. B is actually half of I band. Now, within the A band, there is a slightly lighter area, which is called the H zone. And what is H zone? This is only myosin, no actin. Within the dark band is myosin plus overlapped actin, and within the dark band you have a slightly lighter area which is called the H zone, that is only myosin. Remember, the lightest is of course the I band. Now, so that means this will be myosin only. Decussation of ascending spinal pathways occurs mainly within which of the following segments? Now, ascending spinal pathways, the two major ascending spinal pathways are the posterior column or the dorsal column medial lemniscal system. So let us see, how do the fibers of the dorsal column or the posterior column ascend upwards? These are sensory tracts. This is a cross section of the spinal cord which I've drawn here. The grey matter, this is the dorsal root. There is the dorsal root ganglion. The first sensory neuron is the DRG cell, dorsal root ganglion cell, which is a pseudo-unipolar neuron. What is a pseudo-unipolar neuron? It appears as though the cell has one process, but in fact it has two. One which will carry impulses from the periphery and the other will take. The central process will carry the impulses to the spinal cord. So now if you look at the central process, it enters into the spinal cord, goes into the posterior part of the spinal cord and ascends upwards. No synapse anywhere. The first synapse will be at the level of the medulla. This is the first synapse. This is nucleus gracilis and nucleus cuneatus. From here arises the second order sensory neuron, which crosses over to the opposite side and goes to the opposite side thalamus. Which nucleus of the thalamus? Ventero-posterolateral nucleus. Here you have the second synapse, and the third neuron arises from the thalamus and goes up to the sensory cortex, which is the post-central gyrus. This is the path taken by the posterior column. The important point to see this is, where does the decussation or the crossing take place? Crossing is at the level of the medulla. And which neuron is crossing over to the opposite side? First, second, or third? Second. Let's see what happens in the spinothalamic tract. Spinothalamic tract is meant for pain, temperature, crude touch, itch, tickle, sexual sensations. So let's see. Again, the spinal cord, the dorsal root. There is a dilatation in the dorsal root, which is known as dorsal root ganglion. Here you have the first order sensory neuron, which is pseudo-unipolar. When you give a stimulus on the skin, the impulse will go via the peripheral and the central process towards the spinal cord. Now here, the first synapse is in the dorsal horn itself. The second order sensory neuron arises from the dorsal horn and now crosses over to the opposite side and ascends upwards. So crossing is being done by the second order sensory neuron here as well, but the level of crossing is the spinal cord. In the posterior column, level of crossing, medulla. Here, the level of crossing, spinal cord. It synapses with the thalamus. Which nucleus of the thalamus? Ventero-posterolateral nucleus. And from here arises the third order sensory neuron, which goes into the sensory cortex. So if you look at this question, where does the decussation or the crossing take place? This will be in the spinal cord and the medulla oblongata. Which tract crosses over to the opposite side in the spinal cord? Spinothalamic. Which tract will cross over to the opposite side in the medulla? Posterior column. Let's have a look at the next question. Mechanism of ANP, mechanism of action of ANP, atrial natriuretic peptide, is via which of the following mechanisms? Now, ANP uses cyclic GMP as the second messenger. This is something, again, which you have to remember. The second messenger for ANP, in fact, the only hormone which is using cyclic GMP is ANP and BNP, brain natriuretic peptide. So this becomes a very simple question. But let's have a look at two important points as far as this question is concerned. Now, which hormones do not need a second messenger? Growth hormone, prolactin, erythropoietin, insulin, and IGF-1. Growth hormone, prolactin, and erythropoietin do not need a second messenger because they act via the JAK-STAT pathway. Insulin and IGF-1 do not need a second messenger. What is IGF-1? Insulin-like growth factor 1, also called somatomedin C. These do not require a second messenger. This is because their receptors have tyrosine kinase activity. Both the insulin receptor as well as the IGF-1 receptor have tyrosine kinase activity. So these 5 hormones do not need a second messenger. And this is a question which has been asked quite frequently. Let's have a look at which are the hormones which use cyclic AMP and which are the hormones which use inositol triphosphate and diacylglycerol. So the way to remember this is, let's look at all the hormones as hypothalamic, which are the hypothalamic hormones, anterior pituitary, posterior pituitary, and miscellaneous. So hypothalamic hormone, CRH, corticotropin releasing hormone, This uses cyclic AMP. So easy to remember, C for CRH, C for cyclic AMP. All other hypothalamic hormones will use the inositol triphosphate and the DAG mechanism. That is GHRH, GnRH, TRH. Anterior pituitary hormones, all anterior pituitary hormones, ACTH, MSH, TSH, FSH, LH, all are using cyclic AMP, except, of course, growth hormone and prolactin, which do not need a second messenger, that I've already discussed. All other hormones of the anterior pituitary use cyclic AMP. Posterior pituitary, ADH, V2 receptor, cyclic AMP, V1 and V3, inositol triphosphate and diacylglycerol. Oxytocin is also using IP3 mechanism. For glucose metabolism, glucagon, insulin, remember, does not need a second messenger. Parathormone and calcitonin for calcium metabolism. And adrenergic response, beta 1 and beta 2 adrenergic response, they all use cyclic AMP. Angiotensin 2 and alpha 1 adrenergic receptor use IP3. So once again, hypothalamic hormones, CRH, cyclic AMP, others, IP3. Anterior pituitary hormones, all of them, cyclic AMP, except growth hormone and prolactin. Posterior pituitary hormones, V2 receptor, cyclic AMP, V1, V3, IP3, and oxytocin, IP3. Miscellaneous, glucagon, cyclic AMP. Both the hormones for calcium metabolism, parathormone and calcitonin, cyclic AMP. Beta 1, beta 2 adrenergic response, cyclic AMP. Angiotensin 2, IP3. Alpha 1 adrenergic response, IP3. Let's look at this question. Now, this says a 60-year-old patient complains of progressive shortness of breath, productive cough, wheezing for the past 5 years, and he has a positive history of smoking. So obviously, this is a patient of obstructive lung disease. Now, in obstructive lung disease, what is the flow volume loop? So before that, let's have a look at what is the expiratory flow volume curve. For this, we have lung volume on the x-axis and the expiratory flow rate in liters per minute on the y-axis. So how do I record this curve is, my instructions to the patient are take a deep inspiration, maximum inspiration. His lung volume will be at total lung capacity. Now I ask him to breathe out into a special spirometer. He has to breathe out forcefully and as fast as possible because the spirometer will record the expiratory flow rate. So what do we find? Initially, as he starts to breathe out forcefully, there is an increase in his flow rate. It reaches a maximum of 400 liters per minute, and after that, in spite of him using his effort to breathe out forcefully, the flow rate, instead of increasing, now starts decreasing. Now, the lung volume at the end of maximum expiration is residual volume. What is the width of the loop? What is total lung capacity minus residual volume? Forced vital capacity. This maximum height of the curve is the peak expiratory flow rate. This width of the curve we said is forced vital capacity. Let's divide the forced vital capacity into 4 parts. This is 50% of vital capacity. This is approximately 25%. This is approximately 75%. Now there is another important parameter which is called MEFR, mid-expiratory flow rate, which is forced expiratory flow rate between 25 and 75% of vital capacity. So I will extrapolate these points to meet the curve. These are the rates between 25 and 75% of vital capacity. I take an average, I will get the MEFR. So this is an expiratory flow volume curve. Now, what is a flow volume loop? Now, this is expiration. This is an expiratory curve. he started the maneuver from total lung capacity up to residual volume. Now, when he is at residual volume, we ask the patient to take a maximum inspiration and we get an inspiratory curve. Together they form a loop. So above the horizontal line is the expiratory curve. Below that will be the inspiratory curve. But please remember, expiratory and inspiratory curves, the shapes are different. In expiratory curve, initially the rate rises and then starts falling. Whereas inspiratory curve is more uniform. But remember, height of the inspiratory curve is almost the same as the expiratory curve. Now let us try and understand what happens in obstructive lung disease. Now in obstructive lung disease, the total lung capacity is increased, residual volume is increased, forced vital capacity is normal to decreased. FEV1 by FVC ratio is definitely reduced. PEFR is reduced. MEFR is markedly reduced. Diffusing capacity is normal except in emphysema. So these are the features of obstructive lung disease. Our patient here has obstructive lung disease. Now, if you remember, what did we have on the x-axis? Lung volume. And since he starts from total lung capacity, which is maximum lung volume, and ends at residual volume, so what will happen to the lung volume from left to right? Reducing, right? So 6, 5, 4, 3, 2, 1. Total lung capacity is approximately 6 liters, residual volume approximately 1 liter. Now, if I say that the total lung capacity has increased in obstructive lung disease, so this will be to the left of normal. Now, we record the flow volume loop in the case of this patient, and what do we get? We get something like this. Total lung capacity is increased. Residual volume is increased. It's to the left of normal. Right? The PEFR is reduced and the MEFR is markedly reduced. This is called a scooped out curve. This is typically seen in obstructive lung disease. So this is an obstructive airway disease. So these were the questions for today's quiz. Thank you.